Good evening, happy Wednesday, and welcome to Health Plus Weekly. I am Dr. John Podkowa. I'm joined by my co-host, nurse practitioner Hannah Raymond. And tonight's show, we plan on talking about common medications in primary care that we prescribe, that many people ask us about or have questions about, and kind of the pros and cons of them and some of the things we'd like people to know about. As always with the show, we encourage you to write in via Facebook any of your questions or comments regarding general medical care. Medication questions specifically would be great tonight if you have them. And as we don't have a guest tonight, so again, the audience is our most important guest tonight as we move through our agenda. So please feel free to send the questions in through Facebook, and Hannah and I will try to get to them as quickly as possible. Also tonight, we were trying to learn more about our audience and who's watching. We are thrilled about how popular the show is becoming and kind of the buzz about it. So we want to, thank our viewers who turn in, our regulars and the new people who are watching. But tonight, we're also thought in terms of writing in, people pop in and say hello. If you tell us a bit more about yourself, kind of where you're watching from, what communities you're in. We're just curious to know the reach of the program and where our listeners are. So before we get started, I'd also like to make some announcements in terms of some things going on at Southcoast. Right now, voting is open for areas best of the best. If you visit our Southcoast Facebook site, you can find out more information to vote for, best hospital, best urgent care, best place to work, best primary care doctor, and if you feel Southcoast fits any of those, we'd love to hear from you. Also, in terms of a great cause in the Dartmouth area on May 17th, selected restaurants are going to be announced that when you dine there on May 17th, part of the proceeds will go to the Children's Hospital and Emergency Department at St. Luke's Hospital. Those restaurants are not announced yet. Stay tuned to our Facebook website when they will be announced on May 7th, I believe. But it's great to dine out and also benefit our local hospitals. And finally, recently in the news, you may have seen Barbara Bush passed away, our former First Lady, and she had chose comfort care at the end of her life, and which is a topic we'll bring to the show in the future, but we want to make people aware of that our own Southcoast Visiting Nurse Association offers a comprehensive hospice and palliative care program that does a wonderful job for people who are seeking quality of life at the end of their life.
And more to come on that, because we'd love to have the VNA services on.
Absolutely.
To talk about everything that they offer the community as well.
And they rely on a great team of people to provide the care that they do. And actually, they're currently recruiting for volunteers for the VNA. And what do volunteers do? They spend time with patients. They offer respite or places where patients can go, sometimes for families to take a break. They offer companionship and comfort to some patients when they need it, and they usually kind of work about 2 to 3 hours per week, and the VNA trains everyone. So if you are interested in volunteering for the VNA, there's a phone number you can call. It's 508-973-3219. Again, that's if you're interested in being a volunteer for our Visiting Nurse Association. The phone number is 508-973-3219.
But in other news, before we start, we didn't recognize this last week. You look like you're walking a little better this week. You ran the Boston Marathon for the second year in a row.
Yeah.
So how are you recovering? How is is today kind of a flashback from the weather?
Oh my gosh, it's so funny. Someone I ran with just mentioned that. Thank you. It was a great run. It was really hard. It was my second time running Boston. I run for Dana-Farber on their team, which is a great experience. My best friend from college and I ran together this year, and it was his first marathon. We finished, a little bit over 5 hours.
It's okay. You don't need to mention it with the weather.
So not as fast as we wanted to, but it was an incredible day. Despite the horrendous weather, there were so many people out there, kind of supporting and cheering. And it's slowly getting easier to sit down and
stand up.
And thank God that we don't have a very active show, because you would have noticed me wincing last week.
Last week especially.
Yeah.
That's great. Congratulations.
Thank you very much.
So we have a lot of people writing in so far. The Dartmouth area, Mattapoisett, Rochester. So
that's awesome. You guys are the best.
Wonderful things. So that's great. So in kind of talking about common medications that we see in primary care, discussing what we see frequently, the first thing that came to both of our minds were things to help treat pain for musculoskeletal injuries or kind of prolonged ailments. So we can talk about a
Sure.
couple different classes of the medications that we would commonly use
Yep.
in primary care for aches and pains.
And 70% of us will have low back pain or back pain at some point in our life. So neck pain, low back pain, elbow pain, knee pain. I'm sure this is ringing a bell with some of our listeners out there.
Yeah.
So let's start with over-the-counter stuff that people should have available to them.
Sure. So a common kind of a confusion that I encounter a lot is, I'll say, are you taking any ibuprofen? And they'll say, no, I'm not taking ibuprofen, I'm taking Motrin. Despite, and that's the trade name and the generic name, the same medication. So ibuprofen is a non-steroidal anti-inflammatory medication. So decreases inflammation in the body without being a steroid.
Yep.
So some common generic names for that are ibuprofen and naproxen. Those trade names, Motrin, Aleve.
Yep, Aleve.
Is another big one.
Yeah.
So, kind of in dosing for people, if someone has like an acute, like, oh, I hurt my elbow or my knee is a little achy, what do you recommend for kind of a dosing regimen for people?
Yep.
Not to take long term, but just kind of in the short term.
So I think these medications are great and work very effectively. And so, usually with, I think starting with ibuprofen, which is Motrin or Advil, usually they come in 200 milligram tablets, and the over-the-counter prescription strength is usually 200 to 400 milligrams. And you can take them, usually I tell people 3 times a day is a pretty safe way to start. And I think an important concept with pain, which we talk about in the clinic, is to take medications on a bit of a regular basis for the first couple of days to try to get ahead of the pain and calm down the inflammation or whatever driving the pain. I kind of likened it to, if you're pushing something heavy, it's easier to keep something moving once it's moving versus kind of getting it going from the first time.
Right. So even if you're not feeling kind of inflamed or pain at the very moment, you still would recommend maybe 400 to 600 milligrams of ibuprofen 3 times a day with food.
Yeah.
Also, and what's the story with food? Why do we worry about that?
So I think without kind of talking to your doctor, I think I wouldn't go above 400 milligrams. And the medications, why do you worry about the medications? What are the risks? They can irritate the lining of your stomach and interact with the kind of chemicals that regulate the lining of our stomach. So one, we want to take them with food. It's really important because that kind of buffers our stomach, so it's not quite so irritating. And the other thing you have to be careful with the medications is they work and can affect our kidneys. So I think taking them with a healthy amount, a fair amount of water or fluids, just to make sure that you're staying hydrated. Which is another good question of like who maybe shouldn't jump right to these medications.
Right. So people with chronic kidney disease, so if you have diabetes with known kidney dysfunction, that would be something that we would want you to stay away from. Also, another important class of people are people who are taking aspirin for heart disease. So if you have known heart disease, so not just for prevention, but if you've had a heart attack or if you've had a cardiac catheterization and we know that you have some blockages in your heart and you're being treated medically for that, the ibuprofen can kind of compete with the aspirin and kind of decrease the positive effects of the aspirin. So I think that's important for people to know too.
And if you have a severe heart history, you also have to be careful because they can raise the risk of heart disease a little bit. They can raise blood pressure a little bit. And certainly if you're dehydrated or you've just come from a big run or exhausted yourself or you're sweating, you got to be careful.
You've
just run the Boston Marathon in a non-tsunami day, you would want to be careful.
Careful with that.
And I think those medications are okay to take for maybe a week or two, but if you're not improving, then maybe check in with your doctor.
Okay, good. Yeah. And what about people with known like gastric ulcers or we would want them to also avoid the ibuprofen, the NSAID medications as well.
Yep.
So another over-the-counter medication that we use commonly is Tylenol or acetaminophen, is the generic name there. What's your kind of feeling on the anti-inflammatory effects of ibuprofen versus acetaminophen?
So great question. So 2 different drugs, 2 different mechanisms of action in their body. So you can use them together. Both medications are good at doing certain things. Both medications relieve pain. Both medications reduce fever. ibuprofen in the NSAID or the non-steroidal anti-inflammatory class like we spoke about, the Aleve, Motrins, Advils, they are excellent anti-inflammatory medications where the acetaminophen, Tylenol are not. They're good for pain. They're good for reducing fever. So if it's an inflammatory condition, I would, if possible, I would actually recommend staying away from them and going more towards the non-steroidal anti-inflammatories. But if you needed additional pain control, you can certainly add in some acetaminophen, Tylenol. Yep, okay, and they work very effective with fevers as well.
Right, right. So we have some great questions here as well. So Kristen, just going back kind of off the topic of pain medication, had a question about children taking Trileptal. I will probably have to defer. We'll have to defer that question as neither of us practice in pediatrics.
Yeah, thanks, Kristen. I'm sorry. We are going to do our best to get pediatricians back on the show.
Yep.
Yeah.
And then Susan Mello had some great comments as well that you shouldn't take ibuprofen or steroids, which we'll get to talking about too for long term, and like you talked about there.
Thank you, Susan. Great point.
Yep.
That if something's persisting, I think for more than a couple of weeks, even at longest, to make sure you check in, because there are definitely repercussions of staying on medications for longer than necessary.
And it's not unheard of to be prescribed kind of a prescription strength or prescription type of anti-inflammatory medication, but a lot of times we see that done by a rheumatologist or an orthopedic surgeon. So after kind of down the road a little bit when other therapies haven't been effective. One
of the things we talk about in our clinic when we see patients, Hannah and I and the physicians, is just the concept of, with medications or surgeries or procedures, is you want to make sure the benefit is really high and the risk is really low. And then that's the best case scenario, because with anything there are risks. And so as the benefits decrease and the risks elevate, you get into a situation where you don't want to be at. So I think it's really important to think about that when you choose medications, and we can talk about them in terms of, antibiotics, pain medications, blood pressure medications, a host of things, what we want and what you want to, even when you talk to your doctor or your caregiver, you just see what are the benefits and what are the risks, and
make sure that there's
a really big balance, spread in between in an ideal world. That's what we want.
Yeah. So another great comment from Tilly, actually. She said her daughter fractured her ankle, and her orthopedic physician told her not to take ibuprofen because it impairs bone healing, but to take Tylenol instead. But again, as you just touched on, the ibuprofen has a bit more effect on pain and inflammation. And so she's just asking our opinion on that. So certainly that's a great point. That in that case, I would
Hi, Tilly.
Yeah, I would follow the instruction of the orthopedic surgeon that it can impair bone healing, especially in a pediatric.
Yeah, and after surgery, so kind of a disclaimer too that Hannah and I are talking about kind of general concepts regarding medications. There are exceptions and there are nuances to every single kind of patient experience and environment. So Tilly, you're absolutely right, and the orthopedic you saw is correct. Certain fractures, post-surgery, certain procedures you want to stay away from, or ask your doctor about which medications you should absolutely take, because it can affect these medications, some other risks of these medications. They can affect bleeding, they can affect certain healing in certain scenarios. So a really important point to address here, I guess, is when you see your doctor or nurse practitioner or caregiver, to make sure you tell them all the medications you're taking, not just maybe the ones that are prescribed to you by your doctor that you pick up at the pharmacy, but also over-the-counter medications, because they can affect the way we treat you. They can affect the outcomes of certain things. So even though you don't get a prescription for certain medications, they are very real medications that are available over the counter. So absolutely.
And can be very harmful.
Yeah, and beneficial, but can alter the course of things. Yep, right, absolutely.
Right. So great questions coming in. A question from Mary asking, what's the best way to destroy medications that a caregiver's patient refuses to take, and that's including edibles and pills? Now, actually, I just saw on the New Bedford Guide website there was a posting that the New Bedford Police Department is hosting a pill take back. So maybe if you can access, or we can put up on the website, or put up on the screen, the information for the police department taking back unused medication, which is a really important point. We know that contributes to some of the trouble with prescription drug abuse that we have, is leftover unused medication. So certainly And I'm not actually sure. We're planning to have some pharmacists on in a couple of weeks, and I think that they can speak a little bit better to pharmacies taking back use medication. Do you know anything about that?
I think there's different pharmacies that have different protocols.
Okay.
You definitely want to try to avoid just flushing down the toilet. I think that's
Right.
you should know. But I think contacting whether it's the police department or the local pharmacies can help you in terms of the more serious medications and how best to dispose of them.
And our fabulous producer Josh just put the link to the medication drop-off. So that's actually year-round at the New Bedford Police Headquarters. And that address is up in the comments section as well. So thank you for the great questions. So we talked about ibuprofen, we talked about Tylenol. What are some other, more prescription medications that we would use for pain relief?
So you can get into the prescription strength ibuprofen, which is usually the 600 milligram, 800 milligram doses, which is a very powerful pain medication, kind of along the same things we were just talking about, same kind of things you want to be careful. Then there's steroids, which we prescribe, oral steroids, prednisone or Medrol dose pack people may have heard of.
And again, that's just a kind of a anti-inflammatory on steroids.
Yeah, and it works at a different part in the body, kind of a different pathway, a little bit higher up. They are more potent often, and with more potency comes greater risks and side effects as well. So they are excellent at relieving certain types of inflammation and also in other certain conditions. But some common side effects of those can be they can make people not sleep, they can make them a little jittery, they can make them very hungry.
Raise your blood sugar if you're diabetic.
If you're diabetic, they can raise your blood sugars. They can
risk for some bone.
Yep, long term you got to be careful because they can affect bone health and osteoporosis and fractures. So and usually in primary care we try to use the least potent in all specialties actually the least potent medications possible. Oral steroids are often prescribed in short courses in primary care. Sometimes if you see a specialist that prescribed safely for longer periods of time, but just requires a bit more monitoring.
Okay, great. And what about muscle relaxers? Do you use those at all in your practice?
I do. I think there's a role for muscle relaxers in certain sprain strains for a kind of a brief 5 to 7 period of time. I'm not sure about what your experience. The literature on them is in terms of not super strong one way or the other, but I feel some people respond pretty well to them and some people don't like them.
I tend to kind of let the history and kind of what the patient's feeling dictate whether I'll use a muscle relaxer or not if they're describing more of a muscle tension. And sometimes even on the physical exam you can feel a tense muscle or a knot in the muscle, and I find that it can be helpful at that time too. We had another comment from Susan Mello. Susan, you're on fire, and you may be replacing us as host soon because you have a lot of good information. She also said that CVS has locked drop boxes for medications. So thank you very much for that.
Thank you, Susan. Moving kind of up in terms of intensity of pain medications, there's the opiate or narcotic medications commonly known as, whether it's Vicodin or oxycodone, Percocet. And those, work in a completely different mechanism than the anti-inflammatories and the acetaminophen. They work on pain receptors in our body and have blunting pain. And in my opinion, they're having, a decreased role in how we treat pain in medicine. Certainly for short-term pain, they are in the right scenario appropriate for short periods of time. To control pain, whether it's around surgery or severe fractures, but there are significant risks with them as well. They're sedating. They can affect your breathing patterns. They can cause constipation. So I know certainly in our practice we are very infrequently using them. If anything, for 2 to 3 days at most. We recognize now that certain people have very complicated pain problems, and there are a whole specialty dedicated pain management, which we will have on the show in the future also, who are experts in administering these medications safely and appropriately, because there are people who need them and benefit them from long periods of time, but I think it's outside the scope of primary care, but it's an available option.
And just to know, Susan also noted that people want options in terms of their pain management, and I'm finding more and more that people are wanting, have chronic pain and want to address it, and it's really affecting their quality of life, but they don't want a narcotic or an opioid pain medication, and they're more open to trying some of the, the different and wonderful and useful therapies that are out there too. So that's been a nice kind of shift in what we're seeing in primary care.
I will say I've seen this, I'm not sure if you've seen this in clinic, just talking about different things too. When people travel and go outside the country, I've had a couple instances where people other countries have different laws and things, and they've bought an over-the-counter pain medications, which are thought, and they have been really potent, or they've, and so if you're outside the country and you go to the doctor or you go to the pharmacist, really pay close attention to what medications you're buying. You can often Google them and seeing it kind of the equivalents to the U.S.
Or the translation of the actual
because
thing.
I have two scenarios where people were prescribed high dose like ibuprofen-like medications outside and actually hurt their kidneys because they weren't aware of it. So especially anything you take, just make sure you're understanding. If you can talk to the pharmacists about it, who are often excellent resources regarding, you can discuss with them what medications you're on right now and whether or not this medication is appropriate for you. Especially
helpful with over-the-counter medications, even though you can get in this country too.
Yeah, we actually have 2 retail pharmacy clinics at Southcoast. Actually 3. They're in the Fall River at Charlton, in St. Luke's, and in Fairhaven. So who are always available to help with those types of questions as well.
Barbara Harris just wrote in and said that cortisone shots have worked very well for her in terms of pain management, and that's certainly one of the alternative therapies that would be under the direction of either the pain specialist or the neurosurgery department also that we would work with. So we're planning to have both of those specialties on, so more to come with that as well. So did we cover pain?
I think we briefly, got through most of the questions regarding it. Cardiovascular medications, I think next kind of in line, maybe in terms of high blood pressure, high cholesterol.
So I hear, I don't know about you, but a lot of controversy around statin medications. So cholesterol, lipid-lowering medications. I think there's a lot of controversial information about like you talked about earlier, the risk versus the benefit of the medication. And I think there is a small risk associated with those medications, but the benefit, we know, especially in particular situations, greatly outweighs the risk. So could you want to talk a little bit about what those medications are? And
first, so let's talk about cardiovascular disease, why we worry about it in terms of keeping people healthy long term. What are the leading causes of death in this country? Number 1 and 2 is cardiovascular disease, followed by cancer. So heart disease is out there, and heart disease is...
And meaning, plaque buildup in the arteries, in the coronary arteries. So you hear heart disease said a lot, but what does that mean? So it means, actual plaque buildup in the blood vessels that supply the heart with its blood supply and allow it to beat. So that's what we're concerned about.
Yeah. And things that cause that is a buildup of, cholesterol, which in our body needs cholesterol to build certain parts of the body, so there's a necessary component of it. But when you get too much of it in the wrong places, it lays down these plaques in blood vessels, not just around the heart. It can, it can put them in the neck and through the kidney, in a host of places in your legs. And so that is one of the things that leads to heart disease. Smoking, kind of raises your risk. High blood pressure raises your risk, and as these plaques get, kind of laid down, they can build up and they can become unstable, and they can cause a heart attack or affect your heart or stroke. Yeah. So ways to reduce our risk of heart disease is not smoking, which we can talk a little bit about, the medications to help kind of quit smoking as well. Lowering blood pressure, which we're going to talk about, and then lowering cholesterol, and then aspirin in terms of I think are the important topics to touch on. So the medications that have been out for years are what people hear, the statin medications, the Lipitors, the Zocors, Crestors. And when you talk about what we were talking about before in terms of benefit and risk, I think this is one of the best examples of a decision that's really, really straightforward in terms of really good benefit, really low risk in terms of medication. Heart disease is number 1, cause of death in the country, kind of second in Massachusetts right now. Medications have been out for a really long time, safely studied in like multiple trials, in really good academic centers that have shown to not just reduce heart attacks, but actually reduce the risk of death. and stroke, and they're also generic now and widely available. So, and they work really effectively. They lower cholesterol by 40 to 60% depending on the type of medication that you're on. And I think one of the common questions, I'm not sure about you here, regarding these medications, if I have to start a cholesterol medication, do I have to stay on it forever?
Forever, right. So, and my answer to that, because generally we tried a trial of lifestyle changes before that, in terms of changing your diet, increasing exercise, and we do know that kind of if you take away, so your body builds, makes cholesterol naturally, but if you take away all of the kind of exogenous or X factor sources of it through your diet and not smoking and exercising, and it's still high, then we can kind of arrive on the fact that maybe you're genetically just predisposed to having a higher cholesterol level. And I kind of, you like to think that you can heal anything, on your own, like if you try hard enough, but certain things, we do know that medication is beneficial and can help. So in that scenario where if the person has tried everything and has made all the changes and there's really no room left to kind of cut out those factors that would lower the cholesterol, that may be a scenario where they would have to be on the statin medication for the rest of their life. And then certainly for people who have had, like I said before, documented heart disease or stroke or peripheral vascular disease, that might be a scenario where you might have to stay on the medication forever. But for other people, it's not. It's
a bridge.
It's a bridge. Yep. And I'm love the thought and tell people all the time when starting a new medication, the goal is to get you off the medication if it's possible. So I would never say never in terms of transitioning off.
Absolutely, and it's one of the discussions we have. Like, we know you want to get there, or just we don't want to put you at unnecessary risk while you're changing your diet, while you're getting. I mean, let us put this on, and then we can reevaluate it. They work really quickly. You can usually see the results within 2 to 3 weeks, honestly, in lowering the cholesterol. So people worry muscle aches.
Muscle aches, yeah. So prior to starting the statin medication, we usually, the guidelines are you have to have a baseline, liver function test, and then you really don't ever have to check it again unless you're, having symptoms. So kind of the idea of this close monitoring for blood work to, check for any side effects of it, we don't do routinely unless you come in complaining of the most common side effects, which are muscle aches, fatigues, kind of, and some people can have some pretty pronounced side effects, but are those the most common things?
So I think, they can, in a small portion of people, they can make their muscles hurt, and seriously, and they know that right away. Some people less as severe may experience some just generalized kind of like aches and pain.
Fatigue.
Then we know they can raise your blood sugars, mildly. So it's something to be aware of. There are other factors also kind of driving up those blood sugars. Usually people who are a bit overweight and have other risk factors for raising their blood sugars. So that's out there. And you're right. In the medications work in the liver, so we want to make sure your liver is working well before we start. And then you're right. In the years past and before, there was frequent blood tests for these medications, maybe 2-3 times a year. Now, honestly, a lot of it comes down to, are you taking the medication and just yes, then you don't have to check it because things are going well. Personally, I usually check it once a year, sometimes twice, depending on patients want, if they see how they're doing on it.
So for the cholesterol,
yes,
the cholesterol lowering, but in terms of the side effect monitoring,
No, I usually once a year check the liver enzymes and kidney because they're on other medications as well. And with the newer medications, the Lipitors and the Crestors, which are now generic and have names like atorvastatin or rosuvastatin, what's nice about it is that sometimes people feel a little bit achy or don't like the way they make it feel. You can take them every other day, or even spread them out and still get some benefit from them. So it's not an all or nothing, which is really, really great.
We have a question from Holly asking, what is a good diet to follow if you have high blood pressure or high cholesterol levels? And that's a great question that I know we've touched on a lot. So for high blood pressure, and it does go hand in hand a bit too, we always think about restricting salt, so less than 2 grams of salt a day, and I usually think of like a teaspoon of salt as a gram of salt, and that's in the amount of salt that you add to your food, and then that also comes in your food. If you're buying prepared foods or eating out, you have to take that into consideration, as well as snacks too, which can, crackers and breads can have a hidden source of salt in there too. Also for high blood pressure, decreasing alcohol intake, getting proper amount of sleep at night, and not smoking and exercising.
You can Google and look up like the DASH diet,
DASH,
which stands for Dietary Approach to Stopping Hypertension, has been well documented in terms of its success in reducing the risk of blood pressure and improving kind of outcomes. So that's a simple one to follow. For hypertension,
and what do you usually recommend for cholesterol lowering diet?
And just one more thing on the blood pressure, though, is also diet's rich in potassium. Potassium-rich foods naturally lower blood pressure, and sodium raises it, like you said. For cholesterol, you want to reduce the fat in your diet. So where are sources of dietary fat in our diets? A lot of them comes from animal proteins, so red meats, kind of high-fat meat or animal, so pork, red meat.
So the chicken thigh instead of the chicken breast.
Yes.
Right.
Dairy, butter, margarine, cheese,
the whole milk.
The whole milk.
And those lovely, I know we've talked about it before, soft cheeses and delicious treats there.
And then increasing fiber in your diet is an excellent way to kind of help reduce cholesterol as well, because it traps in your colon. So, just lots of vegetables, high fiber vegetables, artichokes, kale, tomatoes, can do it as well. And then, I actually recommend, we do Metamucil for our patients. It's a great kind of way to add fiber to your diet, simply if you're not getting...
control blood sugars.
Helps control blood sugars, helps with weight loss, helps with not feeling so hungry all the time, helps prevent against hemorrhoids and diverticulosis, and that's over the counter, and it's a great remedy. Oatmeal is another great addition to...
Steel-cut oats has been shown to decrease cholesterol levels. And then just looking specifically at triglyceride levels, which is part of the kind of the type of fat that we look at in your blood, that can be raised by kind of sneaky sources. Alcohol can raise it, and carbohydrates can actually increase that as well. So just kind of looking at things, looking where you need to change. Yeah. And the good news is that the good lipids, so the HDL lipid that we look at is part of the panel, which is actually protective for against heart disease, tends to go up as you kind of change your diet towards more plant-based and as you exercise more as well.
Which is a good question in terms of people have questions about cholesterol. We try to educate our patients. So there's good and bad cholesterol. And I always, like to think and you go through medical school trying to remember things. So HDL, H for healthy, that's what you want. The higher your HDL, the better actually outcomes you have in terms of, heart health. So when you look at your numbers, you know that. And the L is lousy, or LDL. That's more of the cholesterol we've worried about in the past. And then there's the total cholesterol number. Generally, we want it below 200. But when you look at the different components, people often ask us, what does it mean good cholesterol? What does it mean bad cholesterol? Good cholesterol, HDL, actually goes about our body, kind of scavenges cholesterol, brings it back to the liver, and helps it get kind of reprioritized for the right thing. So, like you said, a well-based diet, kind of balance and healthy exercise are the best ways to boost your HDL.
And it tends to be higher just naturally in women as well. So I tell men not to be discouraged if their wives or significant others have a higher HDL.
Yes,
than it's not.
And that can flip a little bit after menopause as estrogen kind of backs away. Absolutely.
Right. So we have some other great questions here. I'm just going to try to go through and make sure that we're addressing everything.
Thank you, everyone, for the engagement.
Maureen, we'll get to your question about a beta blocker for lower blood pressure. So Holly, we touched on talking about a diet for lowering blood pressure and high cholesterol. Susan also mentioned that olive oil helps get rid of plaque. That's part of kind of the Mediterranean diet.
Excellent.
And your son is watching. Redmond is watching.
Hey, buddy.
So hi, Redmond. Hi, Grace. And Edward was wondering about, again, blood pressure, top number, systolic blood pressure is 160. What's a good way of lowering it? So again, just all the kind of dietary changes that we just touched on. Jeanette's a big proponent of the plant-based diet. She says that's the best. Fiber, again, helping prevent against colon cancer, diverticulitis, lowering blood sugars, helping lower some cholesterol as well. And then fiber also helping maintain healthy sugar levels. So Susan, again, you're coming on the show. You're taking over for us. And then Edward's asking, should he use low-fat mayo? So what do you recommend? Because there is, the low-fat debate.
Yes.
And it would kind of depend on his, cholesterol, levels and everything.
I think it's not going to hurt.
Not going to hurt, right?
I mean, my non-nutritionist answer, we've had Heather Haynes on before, but I think it probably won't hurt to try. Absolutely.
And that being said, also there's so plant sterols, which are present in some of the fake butters, can also have a role in decreasing some of the cholesterol as well.
There are other medications if you cannot tolerate the statin medications that can also help lower cholesterol.
So we should say that too, that kind of even though the risk of those muscle aches and pains are low for most people, they do prohibit a small portion of people from actually taking the medications. But there are, so if you do fall into that category, there are other options.
And they don't work, most of them aren't as vigorous in terms of lowering your cholesterol. And they are, something you may have heard of Zetia, which just works in a different pathway at lowering some of the cholesterol. Niacin is an older kind of vitamin therapy that's been shown to reduce cholesterol. And fish oil does not lower the LDL or the bad cholesterol, but has some beneficial effects
for the triglycerides mostly.
And then there are new medications that lower cholesterol that are kind of beyond the scope of primary care. But your doctor can help kind of get you into either cardiologists or endocrinologists to see if you're a candidate for them.
Can help with that.
Yeah.
Great.
There was a question about blood pressure.
Blood pressure medications.
Yeah, so let's transition to that.
So if all else fails and you've made all those wonderful changes in your life and you're not smoking and you're kind of drinking moderately and getting enough sleep and maybe have even been evaluated for sleep apnea with one of our lovely sleep medicine doctors, and your your blood pressure is still high, we also know that there is a genetic component to that as well. And kind of, there's a couple of other things that can cause it, so some renal artery disease, but that is pretty rare.
Yeah.
So kind of in the absence of any of those, those factors, if your blood pressure is still high, there are many options for medications that, again, like the statin medications, are tried and true, well studied. We know how they work. We know how to monitor them.
In terms of kind of putting this perspective for people too, so why we worry about it. Again, cardiovascular disease, like we said, #1 cause of death. Lowering your risk of heart disease. If you smoke and you quit, lowers your risk of heart disease by about 40%. Blood pressure, you go from having high blood pressure to normal blood pressure, lowers your risk of heart disease by about 30%. So it's second. Lowering your cholesterol about 20%, and then aspirin gives you about a 10% protection. So blood pressure is really important. Some people say it's the most preventable cause of death in the world. We know it, by lowering your blood pressure, it reduces risk of stroke and heart attack almost immediately. And this is another question of, if I start the medication, will I have to go on it forever? I mean, we empathize with people all the time, in terms of, they just feel, kind of dejected that they have to start a medication. Because a lot of times you don't feel well with high blood pressure. And, but again, it could be a bridge drug where we just want to get you safely controlled until you lose the weight, until you change the diet. But like Hannah said, unfortunately, some people have high blood pressure and are doing everything right, and we want to kind of reduce their risk. So it was Maureen's question regarding beta blocker, right?
It was actually about a beta blocker, and she said she was asking how long should it take for a beta blocker to lower blood pressure, which is a great question.
I would say within probably 2 to 3 days, if not sooner, you'll be seeing the effects of the medications. They work pretty rapidly and are out of your system, pretty rapidly.
And that being said, too, beta blockers, so certainly blood pressure lowering medications can also have other effects, and within that class of medications, the beta blockers actually also are used to control heart rate in a variety of other conditions, atrial fibrillation. Sometimes if you just have kind of benign fast heartbeat, we can use it sometimes for palpitations that are symptomatic. We use beta blockers. And so we do know that they have a modest blood pressure lowering effect. So whereas in years past they may have been the first line of therapy in terms of a blood pressure lowering medication, they may not be the first line anymore.
Unless something is going on,
Unless something is going on where you may need those other other benefits of the beta block.
They help with tremors.
Right.
They actually can help with anxiety. They can help with a little bit of stage fright.
Right.
There is and those beta blockers are metoprolol, atenolol, or some of them are propranolol, or some of the common names out there. They're generic, they're inexpensive, they're available, and so And so what is high blood pressure? When do you worry about it? The new guidelines are actually, if it's above 130, you should start worrying about it. It used to be at the top number, which is the systolic number, and the bottom number is the diastolic number.
And I remember D for down, so my education's paying off as well.
Excellent.
That's good.
Yes. And a rough rule of thumb is those two numbers added together should equal 200. 200, right. It's kind of like, is my blood pressure good or bad? And, whether you go to the doctor's office to get it checked, pharmacy, grocery store, New Bedford Wellness Initiative has lots of blood pressure drives around. The Southcoast Health Van is checking blood pressures. You should have a pretty good idea of what your blood pressure is, I think, at least once or twice a year to make sure that something's not going on.
And there's actually more and more evidence coming out now that if you just see your doctor twice a year and your blood pressure's fine during those 2 visits, that may not be enough information for us to know that you truly have well-controlled blood pressure. That kind of, we call them ambulatory readings, that you're in CVS and you sit down and it's a Wednesday and you've just had a stressful day at work and your blood pressure's high. So we know that if it's high at that point in time, that may not be the only time during the week or during the day when you're feeling stressed and your blood pressure is elevated. And even if you are kind of in those snapshots in the physician's office, have well-controlled blood pressure, it's important that we know that it's consistently well-controlled. So more and more, the home cuffs, taking those readings, taking those opportunities to get your blood pressure checked at any time, and really, reporting. I just tell people, just call us, tell us the readings, we'll get you back in. It may not mean that we start you on medications right away, but at least we can look a little bit closer.
Yeah, it's important to trend, because one isolated time isn't ideal. And so common medications we use to treat blood pressure, the good news is, again, it is a treatable disease that makes a big impact with medications that have been around for a very long time, have been studied in lots of really well-run, excellent trials, and are often generic now and inexpensive. And side effects are low, and the benefits are great. So do
you want to just kind of run through some really common, like primary care, what people might go on?
So water pills, which I think people,
right.
What is a water pill? What's a water pill?
So a diuretic medication, and there's various types, and they work in different ways on the kidneys, in kind of the electrolytes and the filtration system in the kidneys to get rid of excess fluid from your blood that your kidneys are filtering, and by that mechanism they're actually decreasing the volume of blood that you have and decreasing the pressure in the system. I always like to think about blood pressure as the plumbing. So it's just
it's a closed system, right? It's like a heating system.
Yep. So if you take out some of the fluid, the pressure in the system is going to come down. So that being said, we do tend to have to monitor those a bit more closely because they can, number one, affect the kidney function, and number two, with the kind of excretion of the fluid, they tend to take some of the electrolytes that we need in our body with it. So whether it's monitoring sodium with the thiazide type diuretics, monitoring potassium with the loop diuretics, or just kind of in general,
And kind of along that concept, why do we worry about sodium? Just the short answer is because sodium attracts water, which is really interesting. And so the more sodium you bring in your body, it attracts more fluid and drives up your blood pressure.
Your body always tries to equalize the system.
So these medications help your kidneys get rid of the sodium, and the water follows it.
Right.
And a lot of the questions people ask is, well, I feel like I'll be urinating all the time, or peeing all the time, and depending on, one of the most common ones we use is hydrochlorothiazide. It's been around for a really long time. And I think the short answer is no. I think people feel like they urinate a little bit more initially while they're on it, and then they get used to it. One of my patients said it was great. He said it was kind of like when you put your shirt collar on in the morning. You can feel it for a little while, but after an hour, you don't realize you have a shirt on. You just get used to it. Some people say it affects them more, and there's a bit of give and take. Certainly with these medications, we'd recommend you take them in the morning. It's also important to know what type of medication you're on and you're taking it at the right time of day, because there is benefits to spreading out your blood pressure medications, which we can talk about if you're on more than one, which is really, really common. Most people require more than one medication to control their blood pressure, and sometimes there's benefits to taking some in the morning and some at night. But certainly, if you can take your diuretics in the morning so you can get a good night's sleep and not curse us,
minimize it, right?
Yeah, absolutely.
So another class of medications that we use are calcium channel blockers, and there's 2 different types within that class of medications, but the most common that we would use kind of in the absence of any other heart problems like atrial fibrillation would be like an amlodipine or a Norvasc. And that works by actually dilating so thinking about the closed system, if you're dilating the kind of the outer
Pipes.
the pipes, the peripheral vascular system. So again, expanding the pipes, decreasing the pressure, and kind of thinking about that, the most common side effect that we see from that is lower extremity or extremity swelling. So that's kind of the rate limiting factor on those medications as well.
Diabetics, if you're diabetic and have high blood pressure, there's an amazing class of medication called the ACE inhibitors or the angiotensin receptor blockers, which have tremendous benefits beyond just lowering your blood pressure. The ACE inhibitors can just reduce your overall cause of death, they can reduce your risk of heart disease, and they can protect your kidneys. So if you're a diabetic, usually that's the first line type of medication that we often reach to try to kind of just look at your whole medical condition and treat you with the least amount of medications and cover as many bases as possible, and are fantastic.
And those medications are also important for people with kind of left-sided, so the larger pump of side of your heart. If you have some kind of heart failure or a cardiomyopathy, sometimes those medications can prevent kind of the extra buildup or the remodeling of heart muscle, and can have some beneficial effect with those as well. Most common side effect with the lisinopril is a dry cough, and sometimes that can be the cause to get people off of it.
There is no free lunch with medications, so there are side effects. Blood pressure medications, I would say, certainly come with side effects. We should be upfront and honest when we talk to patients. They can make you a bit dizzy at times because they are lowering your blood pressure. So going from sitting to standing positions rapidly or getting up, people may experience a little bit more exaggerated that dizziness quickly. So we recommend that you stay hydrated and you kind of just move a bit slower. If the blood pressure is dropped too low, you can feel a little bit tired and also dizzy, and you can work with your doctor and nurse practitioner office to maybe adjust some of the medications. Unfortunately, in men, they can certainly cause trouble with erections or sexual dysfunction. We'd like to bring it up early so you're not embarrassed and so we can address it, because there are certainly ways certain medications may or may not have as much of an effect on erections. And if we can't get around the medication, there's medications like Viagra and Cialis, which we'll have our urologist on to talk about in the future.
Right. We don't generally love to treat side effects with medications, but there's certainly a discussion is warranted. So we have a couple other questions that we can get through. Why don't we just run through quickly a couple other classes of medications for.
So there's the beta blockers, like we talked about, which are they work on slowing how hard the heart pumps down, and are effective in people with known heart disease. Absolutely, people who may or may not have trouble with tremors, people who maybe there's an anxiety component.
Atrial fibrillation. As well. And let's see what else. So a couple questions from one from Susan, saying that headaches can indicate high blood pressure as well. Certainly if you're having new onset headaches, I think that's maybe overstated a bit in terms of high blood pressure. Most often I see is not symptomatic at all.
But it can be a symptom, yes.
But it certainly can be, yeah. And Jim is asking if a blood pressure reading of 124/61 is good, and I would say that knowing nothing about your history, no matter if you had...
I think you're doing okay, Jim.
Great.
Yeah.
Yep.
I think that's good.
Yeah, I think that's great. Susan also mentioned that water pills can make you dehydrated, which we know, and so that's a conversation after starting a medication of the side effects that would be reportable to whoever's prescribing that medication.
And with blood pressure medications, we frequently see our patients, one, to make sure the blood pressure comes back under control within 4 to 6 weeks, typically depending on where it is, and we check routine lab work, and depending on the patient and other things they have going on, often see them at least once a year, if not perhaps twice a year, to kind of check in on them and see how they're doing.
Yeah. Christian, just kind of a general question, stating that he's not a huge fan of supplements, but sometimes taking them to stay on track makes him feel better. He says that he feels better taking a daily vitamin and Metamucil, but he saw something on Facebook recently about a dietary supplement, Nucific and BioX4, which neither of those I'm familiar with. but maybe a probiotic. And do you have any recommendations for staying on like a probiotic or a supplement long term?
So I think, tackling what a multivitamin is, I don't think, never dangerous. I think certain people benefit it, some people don't. And so depending on how well you eat and balanced and colors are in your diet, I think we all agree that if you can get the most nutrients by eating versus getting a supplement is the best way to do it. But life is hard and fast, and some of us have different tastes. So if you're not getting that, I think a multivitamin is great. Metamucil, I think, is an excellent supplement we talked about for a host of reasons, which are great for you. Lowering cholesterol, equalizing blood sugars, weight loss, protecting against hemorrhoids and diverticulosis. And so that's great. The probiotic question, I think, is appropriate. I use them in the spectrum of a couple different scenarios. I'm not sure about you. If someone has been sick recently with a diarrheal type illness, or they've been traveling and their bowels aren't just right, I recommend them to kind of help maybe get them back on track. Sometimes people who are susceptible to antibiotics and are on them and maybe get some diarrhea associated with them or not, I use them to help them get back on track. I typically don't prescribe them or recommend them long term. I use them in short courses for maybe 2 to 6 weeks, and then back them away. I'm not sure about your experience with using them. Same
in those scenarios, and a lot of people want to try them too. I do find that they're very expensive, so I also recommend this with glucosamine and chondroitin as well. That can be expensive if you're having muscle aches and pains or joint aches and pains. That give it a trial of a month or two, and if you do find that you feel better with a probiotic, maybe you stay on it. But if you don't, then it's probably just and there's no other kind of indicated reason for it, then it's probably maybe a waste of some extra money there as well. So all caught up on questions for now. I
think that's an important point just regarding cost. I think we should get out there in terms of. Certainly, I think at our office, we don't believe that you should really pay more than $20 to $30 for a prescription. I would say, if I try to tell our patients, my patients, if I prescribe something and you go to the pharmacy and it's more than that, I certainly didn't intend that, and that perhaps give us a call back and see if we can get a cheaper alternative, a generic. It's really complicated with the different insurance companies that are out there when they negotiate prices with the drug manufacturers, but. Oftentimes, we can get your medication cheaper. Whether there are certain pharmacies like Walmart, Target that have their own generic supply of pharmacies. I think CVS as well that we can work with you on. Or if that specific medication, there's often a change within the class of the medication that we can get you. Not always. Some medications are expensive depending on your insurance, but I think it's a good thing just to get used to the idea of calling and asking first, like, hey, do I really need to spend $75 on an antibiotic because that stinks,
Right.
And
oftentimes we don't have, when you're ordering a medication through the system, we don't know, and that's, I also stress that I think this is the best option, and this is a generic, and it looks like maybe, with your insurance it might work, but certainly if you get to the pharmacy and it's cost prohibitive, call us, let us know, because we really have no way of knowing from our end at this point what medications cost. A common question people worry about is how many medications are on and how they're all interacting, which is an important thing, and I think it's an important thing to, which is one of the great things about, I think, seeing a primary care office, someone who looks over your whole health history and looks at all your medications in conjunction and how they're interacting with one another to see maybe you can get rid of certain medications, maybe you can simplify, really kind of questioning the benefits, because there are opportunities to decrease medications. One of the most common ones, I think, in terms of we see in the office is antacid medications. Sometimes people have, are on a Nexium or a Prilosec or type medication like that, and they've just been taking it for a really long time, and they haven't tried to stop it in a while. And I think there's really good evidence out there nowadays that we should try to stop them, to back them away, because they can have some unwanted side effects. Right. Which were just discovered, in the last several years. And it's not like if you're on a medication for that long that it was intentional, but just kind of new information comes out, and it's important to kind of not only be your own advocate in terms of saying, hey, can I try off of this medication, or is there anything on this list that you can see that I can get rid of or we can try without? So I think that's an important conversation to have as well. Yep. So we're all caught up on questions. Great. So that's good.
I think we're almost done here. It's almost 8 o'clock. It's hard to believe.
I know. We just scratched the surface.
We just did, yeah.
So I think we'll probably be trying to have kind of a general medical question at least once a month. So people, if you kind of want to, hoard your pharmacy questions or hoard your general medical questions, we'll be making that a regular kind of installment.
Again, New Bedford Guide has the information about where to dispose of medications, which is a really important thing to know. We're going to try to bring on pharmacists in the future for some more detailed
May 9th,
information.
Talk about some diabetic medication as well, specifically.
We want to thank everyone for so much participation tonight. Really awesome, and it's great. And we also are really thankful for everyone tuning in and telling people about the show and the growth of the show. It's been a lot of fun. We will be back next week. Again, just as a couple reminders, voting on the Southcoast website for Best of the Best, Southcoast Facebook site. If you would like to vote for any of our departments, we welcome it. And also, May 17th, stay tuned on our Facebook site for certain restaurants that will be supporting our St. Luke's Emergency Department for Children in terms of a fundraiser. Certain restaurants where you dine out will give some of the proceeds to help raise money for the Children's Emergency Department. And finally, if you're interested in participating in our VNA program, which does a tremendous service to the community, they are looking for volunteers right now. They do tremendous training, and the number to call there is 508-973-3219. And thank you, Hannah, for helping prepare a great show. Josh, as always, thank you for making us look great and sound great. And stay dry out there, everyone. And hopefully, April showers bring May flowers. I'm really looking forward to it. And stay healthy, Southcoast. See you next week.
By the time I graduated high school, I think I was between 275 and 300. I had to buy my dress clothes at the Big and Tall store. Enough is enough. Southcoast Health gave me the tools, and here I am, with my health. And I was a 46 going into 48, and now I'm a 30-inch waist. I'm living proof to show if you put the work in on anything that you can get what you want. Take impossible, throw it out of your vocabulary.
I had 2 blockages. I had to have a catheterization, and told me that we needed to see a surgeon as soon as possible. Dr. G made me feel like I was his only person that he ever did surgery on. You don't have to go to Boston. You can come right here to Southcoast and get the best treatment. I said to him, Dr. G, I guess I'm going to fall in love with you. He says, I know I'm going to touch your heart.